And with that, I think, oh, sorry, the last preliminary I always have to touch on. Just as a general topic, this is going to be an overview of legal issues and considerations. Doesn't establish an attorney-client relationship, and it's not giving legal advice. This topic, unlike some, is more just giving an overview generally, so really just letting you know where we stand in healthcare reform. Now getting into the meat of that, as everyone I'm sure on the call is aware, we are in a new era of healthcare in the United States, and before we touch on where we've come since we've started in that era, I wanted to again revisit some of the reasons that healthcare reform came about. In 2010, which was the year when the Affordable Care Act was passed, the United States was in the top 3 in the world in healthcare spending as reflected as a percentage of the gross domestic product. And that was a number that doesn't seem terribly shocking until you compare that against really what that means in terms of the sizes of our economy. It was, in 2011, healthcare spending was almost 18% of the national economy. And unfortunately, Americans are living longer, but that spending has not necessarily translated into a healthier population, despite that it is a substantial part of the gross domestic product. Healthcare spending is also still projected to grow and increase, in part because of healthcare reform, but the projections now are at an average rate of almost 6% for the next 8 years, which is 1% faster than the average annual growth in the economy generally. By 2022, healthcare spending is going to represent an estimated 1/5 of all spending, or of the revenue in the country. So definitely healthcare spending and healthcare services in the United States are just going to continue to grow. Things that are actually contributing to that growth and are projected to continue to contribute to that growth in healthcare spending are the Affordable Care Act and coverage expansions, and also our aging population. And these numbers came from the CMS National Expenditure Projection Survey. As I said, 2010, which was when the initial spending numbers were from, was the year that the Affordable Care Act became law, and it brought about what has since become the most significant change and started some of the most significant changes in the healthcare system in the United States since Medicare was established in 1965. When the ACA was passed, and as it's continued to be implemented and have different components rolled out through regulation and different decisions by various governmental agencies, the goals of the Affordable Care Act have remained the same, and those were to expand access, to get coverage to individuals who are otherwise uninsured, and trying to make coverage affordable for all Americans, to ensure broad participation to spread risks and costs, and this was also as part of the expanded access to make sure that as people got coverage, that meant that more money was going into the pool to be spread among then claims and payments for services. To contain runaway costs of especially healthcare premiums, as a note, the decade prior to the passage of the Affordable Care Act, health insurance premiums had increased by 120% versus just wage growth increase of about 34%. And then finally, to improve quality of healthcare. And this goes back to the living longer but not healthier comment, and especially trying to curb preventable medical errors and focus on preventative care so that certain care management could help lessen the need for more intense care down the line. Today I'm really going to be focusing, I'll be touching a little bit on some of the things that are some of the ways the ACA has limited cost and spread risk, like the individual mandate and employer mandate. I'll just mention that some of those things are in process, but more so the focus of what I'm going to be discussing is on the provider side of how these healthcare reform topics have and goals have affected the delivery of healthcare, and across provider types have resulted in changes probably in in the way that most of you do your day-to-day activities to some extent, and also more broadly how you're planning for the future. As I said, things like the individual mandate and the employer mandate have rolled out to some extent. The employer mandate, as you're likely aware, has been delayed and implementation changed a little bit. Medicaid expansion has been in many states already implemented. And then insurance exchanges have also been implemented either through the federal exchange or in some states through individual state exchanges. Also, one of the big functions of healthcare reform that's rolled out are some new care models. One that has been a definite buzzword, I think, since passage of the Affordable Care Act was accountable care organizations, ACOs, and also there's other types of new care models, direct primary care, medical home models, some other things that seek to, one, either share savings and or increase quality, or bring a more streamlined process to the delivery of care to individuals throughout the continuum of the providers that they may need to see and access in the course of treatment or in a course of care. And finally, there have been insurance market reforms as well, which go largely to the components of insurance products and policies. After the Affordable Care Act passed, the law mandated that many different changes be made across those different sectors. However, the actual rollout of the reforms in many cases took place through subsequent regulations and involving many different agencies that looked at the charges that they were given through the Affordable Care Act law itself, and then have been implemented or are still being implemented since that time. Already in place, some of the things that went into effect in the first group were some of the coverage reforms. Again, I'm not going to touch on these too much, and you're likely, most of you, aware of many of these things, but the coverage reforms that are already in place include children up to age 26 being able to remain on their parents' insurance policies, removal of lifetime limits on benefits, also removal of annual limits as well. Requirements now that to cancel an insurance policy, you have to prove fraud and allow appeal of claims denials. Some preventative services are available without copay. Small businesses now have the ability to get up to a 35% tax rebate for providing certain insurance benefits to their employees. And there's been the requirement that insurance companies must spend more on their premiums of care and then report their spending. And if they've spent too much outside of actual dollars that went back into care, having to rebate monies back to their policyholders. Many of the reforms are to some extent rolled out, but also still in progress. And so that's where I also, kind of getting into many of the things that are related to providers, I consider most of the reforms on the provider side to be things that are in process or in progress, because while many of them are applicable, they're still developing, data still coming in, and year to year things are either changing because there are scales of the timing over which the reforms will be implemented, or because as the reforms are implemented, programs and components are being adjusted to account for the results that are seen in the years prior. As I noted, one of the big buzzwords coming out of healthcare reform was ACO, the Accountable Care Organizations. And that's one of the alternative payment models and alternative practice models that has come out of healthcare reform. As of August 2013, there were nearly 500 Medicare and commercial ACOs, which were serving at that time an estimated 27 million beneficiaries. So that was and is already a big change in how many Americans are receiving their care now. The goals of these ACO models, whether Medicare or commercial, are to try and, again, coordinate the care, so that a patient has ease of experience throughout their care, and also so that it can, by coordinating care, can reduce either errors or possible complications that might be able to be minimized by making sure that there is coordination among providers. And that's been across specialties, across provider types, and also through things like post-discharge planning. The goals are also definitely, on many fronts, quality, and trying to make sure that health screenings and things that can be done to quantifiably see that there has been an increase in quality occur. Keeping patients healthy through preventative care, and I think the biggest example of that I often hear talked about is trying to get people to see their primary care provider at a primary care office rather than accessing the health system through the ER, because that condition has gotten so serious that then reactionary care is really the only thing that can take place at that time. And finally, which I think touches on actually a lot of the other three items, is to reduce cost by coordinating care, providing more quality care throughout delivery of treatment, and also trying to increase preventative care. Cost of care overall is hoped to go down. The first rollout of the ACOs was through the Medicare's Pioneer ACO program, and it was the predecessor to opening up the broader shared savings program. There were initially 32 Pioneer ACOs selected, and the results that have been released by the Medicare program have, I think, admittedly on their part, given the good and the bad, and there have been some mixed results from those initial Pioneer ACOs. Of the 32, 13 have departed, so that I think is a notable number. The first year results that were released showed that there were some ACOs that had achieved or were working towards achieving the goals of the program, which was to, again, among all those goals on the last slide, at the end, try to contain costs. And so some ACOs showed that they had slowed their spending in the first year by up to 7%. However, on the flip side, some had increased spending by up to 5%. So there wasn't necessarily a key result across the ACOs. And the second year results that have been released were similar. The spending was either increased or decreased in that year by either plus or minus 5%. So it's still kind of a work in process, and those were the Pioneer ACOs that were the first to get up and going. But I think that this has kind of showed that in many ways how successful or how these programs work is probably not going to be a one-size-fits-all model. Since those initial Pioneer ACOs rolled out, the broader Medicare Shared Savings Program has been affected, and now there's over 100 ACOs that are part of the Medicare Shared Savings Program. One key component of the Medicare Shared Savings Program is the ability and the issuance of certain waivers that allow for relationships within these programs that otherwise might have difficulty meeting or may not be able to meet certain exceptions or safe harbors to the fraud and abuse laws. And without going into detail on the fraud and abuse laws specifically, these waivers apply to the anti-kickback statute and the Stark law, the physician self-referral law, and also to the civil monetary penalties law. There were several waivers related to this program which were issued in October 2011 and have since been utilized by participants in the Medicare Shared Savings Program. Those waivers include pre-participation, participation, shared savings distribution, compliance with Stark, and patient incentives. Of note that the compliance with Stark waiver actually gets to the effect that if the relationship would meet a Stark exception, that's then sufficient to address the anti-kickback and civil monetary penalties concerns. Two things that I think are actually really notable about the waivers that were issued under the Medicare Shared Savings Program, and this goes a bit into more broadly what you usually would need to look for to either meet a safe harbor under the anti-kickback statute or an exception under the Stark Law. Usually when you're looking at kickback concerns or physician self-referral concerns, two of the things that you'll find in meeting an exception that would make a relationship okay under the Stark Law or meeting a safe harbor to the anti-kickback statute are that most of those exceptions and safe harbors contain a requirement that the relationship or the compensation in the relationship be fair market value and also have an element of commercial reasonablement. Those are not elements found in the waivers under the Medicare Shared Savings Program. And at first, in looking at these and considering these with providers over the last few years, that was kind of an oddity, but looking more at the reason that these waivers are put in place, and actually more broadly the reason that the Medicare Shared Savings Program has been implemented, I think having those omitted from these waivers actually makes sense because the goal is to reward quality. So it's not going to necessarily be the same fair market value quantifiable look at what would be fair or the correct compensation in a given circumstance and or commercially reasonable. Instead, this is going to be much more case by case and would reward a provider or would allow providers to be rewarded and thereby compensated for providing quality, reducing costs to the care overall, again, meeting those goals of getting a more quality patient experience at the hopefully lowest cost possible by having efficiencies and other things involved. Also, sort of unique to these waivers, not always required under all the other anti-kickback, safe harbors, and Stark exceptions, but there's no requirement for a written agreement. These are self-executing waivers. So if you're participating in the Medicare Shared Savings Program, having your participation agreement alone entitles you to use of these waivers. One significant note that I think most providers that are working in accountable care organization context are likely familiar with, but it I think is worth restating time and time again. Currently, these waivers are only for Medicare ACOs. So you need to be involved in an ACO that's related to Medicare commercial ACO products at this time, while they may still be accomplishing and working towards the goals of healthcare reform and the Affordable Care Act, are not subject and able to utilize the waivers under the Medicare Shared Savings Program. Some of the other big reforms in progress are quality incentives and penalties. And a few of these, some of these relate to hospitals specifically, and this is one that's, I definitely think is in progress because it's, as I mentioned, some of these reforms are one that has rolled out over years and continues to roll out. This is the hospital readmission possible penalty. And this began in October of 2012 and has since been ongoing for the last 2 years. In 2012, when it started, the penalty associated with hospital readmissions was 1%, and CMS has been required to reduce hospital payments with excess readmissions by these various percentages over the last 3 years, with the most recent bump up just occurring at the beginning of October 2014. The readmissions that are looked at in this context are based on predictions of what normal readmission rates for certain conditions would include. The initial conditions were limited to a handful, including heart failure and pneumonia, and the change actually going forward for 2015 and beyond is that for additional conditions and measures, are going to be added. So the list of things that could fall within a hospital readmission and therefore being a hospital or have their payment reduced now in 2015 and going forward will include other conditions like COPD and other vascular conditions. Also, another, and this is hospital related as well, but can be both an incentive and a penalty, is the hospital value-based purchasing program. This started in 2013, and there started with a reduction of 1% in DRG payments. And that reduction has formed now a pool that is going to allow hospitals to have the ability to recoup both the money they paid in and, or not they paid in, but the money that was deducted through that 1% reduction, plus incentive even beyond that, potentially, for meeting and achieving certain quality measures. And the interesting thing, and something that's been discussed quite a bit in this context, is how those quality measures are looked at, and some discussion of if this program is going to be a race to the top, so to speak, because in looking at hospital quality and their achievement of quality measures, the look year over year will be hospitals as compared to other hospitals. So putting hospitals up against one another in that comparison, and also hospitals being compared to themselves in prior years. So the goal is that this will increase care over time, but it will be interesting to see how this plays out, and as information is reported over the next few years, as hospitals are being looked at against their own performance, and how much that can continue to increase or get better, I suppose, and then also when you're comparing hospitals against one another. Some of the most, I think, interesting or maybe juicy things that have come out of healthcare reform on the provider side are some of the changes in fraud and abuse. And this is, to some extent, the Medicare Shared Savings Program waivers could also fall in this realm, but this is more things that have been specifically aimed at curbing fraud and abuse or changing how the government is looking at fraud and abuse. One of the changes was that now that there's an ability for the Secretary of the Department of Health and Human Services to put an enrollment moratoria on certain providers or supplier types in certain locations for in temporary periods, the periods of 6 months. There so far have been, this has been utilized by the Secretary. The first round of the moratoria went out to home health agencies in a couple of different counties in Florida, and also ambulance supply companies in Houston. In the second round, it extended actually that first moratoria. So although it's temporary, it can be extended. It actually then extended home health providers and enrollment of those provider types in several additional counties, both additional in Florida and in some other states, including some in Michigan. That is an interesting, I find that process interesting and very new in healthcare reform, but something that data is also forthcoming on fairly quickly because of the 6-month time period. So it's something that is sort of neat to watch, or intriguing to watch, because the thought process that goes into where the Secretary determines where to place those or why to extend those, I think is something that can be useful even for providers of other types and in other locations to try and understand what the government's looking at, what they're concerned about, and then hedging against that in your practice. In the Medicare and Medicaid enrollment process now, there have been enhanced requirements, including enhanced screening, disclosure, the requirement for compliance programs as a condition of enrollment. I'll actually touch on that piece a little bit further. further on, and those things have increased in a lot more rejection of enrollments, and also made that process just heightened on persons and providers enrolling in those programs. As many or most of you are probably aware, the Medicare program has also gone through a requirement for provider revalidation of enrollment. And that's, again, it's then included some of these heightened enrollment requirements, but it's expanded and extended those not just to existing providers, but also to people that are just, or sorry, not only to new providers, but also to existing providers who have already been in the program for years. And one thing that's of great note, I thought, was that higher scrutiny has meant many more revocations. This next chart was released by CMS, and you can see that since the Affordable Care Act passage, there's been at least, in these states, at least 2 times as many revocations, and in some instances up to 11 times as many revocations of provider enrollment as there had been prior to the Affordable Care Act. And it was kind of shocking when I found this chart to see that it definitely is the minority of states that did not have some effect based on this. And that also doesn't mean that even the states that aren't marked here didn't have some increase, but this is just the threshold of at least 2 times as many. Additional changes that have reforms that are in progress on the fraud and abuse side include credible allegation suspensions. And this is a change that allows for when a credible allegation and investigation is ongoing of a provider, that can actually be utilized to trigger a suspension while that is ongoing. Previously, that type of an action of suspension or revocation or having an effect on enrollment status would not have occurred until after the investigation and conclusion, if that was a negative conclusion, has been determined. Now, while that is ongoing, if there's a credible allegation, as is defined to mean that the government has an investigation ongoing and several factors that have to go into that, there can actually be an up to 18-month suspension, and that's an initial time period. That can also be extended, and depending on the type of investigation, the circumstances involved, investigations can be ongoing for much longer than 18 months. So this could be something that even while a provider has not yet been found to have done something wrong, but had a credible allegation of wrongdoing, that they could still have their enrollment suspended during that interim. Another thing that many have probably heard of are the increase in the utilization of RACs, or Recovery Audit Contractors, by the Medicare program. Specifically, one thing that the Recovery Audit Contractors are doing is checking that all Medicare Advantage, also known as Part C, and Part D prescription plans have anti-fraud plans in effect, and also then to check the effectiveness of their anti-fraud plans. One thing with Recovery Audit Contractors, when they're auditing any type of provider, their recovery, or what they determine, if they determine that there has been some amount that should be recovered from a provider, the Recovery Audit Contractor usually is getting a varying percentage of that recovery. So it's an interesting program that has affected many providers, and depending on the Recovery Audit Contractor jurisdiction you're in, sometimes that process can look a little bit different, and the timing can work a little bit differently, but they're something that certainly, if you get notice or get contact from a Recovery Audit Contractor, I would encourage you to take action quickly and appropriately to be as responsive as you can to one, try and get the best result possible, but also to try and complete the audit and the determination as soon as possible to avoid additional disruption and impact to your practice. Also on the fraud and abuse changes from the Affordable Care Act are changes to the handling of overpayments. The requirement now when a provider knows or has information about an overpayment is that the clock starts running from the time that you discover that there's been an overpayment. And once information is learned that there's been an overpayment, the time period to report and repay that to the government is 60 days. This has been, in practice, something that I think has been something that providers of many types are still trying to get their arms around, because you have to definitely have the threshold of when you know an overpayment is an overpayment, but I don't think that necessarily always looks the same depending on the circumstances, and that there may be some level of information gathering necessary to determine when there's been an overpayment. So trying to pinpoint when that clock starts is an action and a activity that needs to occur really on a case-by-case basis, looking at what you're considering, where the information is coming from, what the information contains, and really then when you've determined that there's an overpayment and therefore your 60 days to repay that it has commenced. One of the changes beyond having now the 60-day requirement is that failing to report and repay an overpayment beyond having that requirement of itself now is a separate violation of the civil monetary penalties law. And as a result, that can be a separate penalty of up to $10,000 per item or service that is involved. It can be up to a 3 times penalty of the damages involved, and it could result in a possible exclusion from federal health care programs. So it's made one determining when you're on the time to report and repay an overpayment important, because that's an obligation in and of itself, but 2, because of the extremely heightened possible penalties for failing to report and repay, it's made it even more important that that timing is something that everyone in your organization is aware of, that the report and repay requirement is something that everyone's aware of, so that there isn't any doubt or any chance to have your reporting and repaying fall outside the 60 days, and try and minimize your risk there as much as you can. The one other thing I wanted to mention, which has been a change, and it's in the fraud and abuse realm, and actually I would encourage, if you're interested in further discussion on that, we actually have had some fraud and abuse webinars that were more targeted to Stark, anti-kickback, some of the more recent fraud and abuse activities, and can give you more details on actual specific actions here. But the Stark self-disclosure protocol has now allowed for providers to make self-disclosures when they become aware of a Stark violation. And their CMS reports, the Stark self-disclosure protocol is administered by CMS, which then reports settlements that it makes in connection with those disclosures. It does that without listing provider names. I check, those are released fairly frequently, and also the settlements that the OIG, the Office of the Inspector General, reaches in regard to anti-kickback or other violations are also reported quite regularly. You can usually check about monthly and see the reports of the last month, but it's quite shocking when you put the Stark self-disclosure protocol and settlements that have resulted through that avenue of someone coming forth, a provider coming forth to CMS saying, here's the issue, here's what we determined, here's what we quantify as the amount involved, versus when the OIG or Department of Justice, DOJ on the more investigative and possibly even criminal side has done an investigation and then reaches a settlement with a provider, the discrepancy in the amounts that are often reached is amazing, because the Stark self-disclosure settlement protocol resolutions often are within the tens of thousands of dollars, sometimes hundreds of thousands, but that's in very sharp contrast with the settlements often reported by the Department of Justice and Office of the Inspector General, which are many times in the millions, even up to the tens and hundreds of millions. So I think that the reporting of those is not something that is probably, I think the purpose of that is hopefully to get information to providers that even if you have an issue where you determine that there's been a Stark concern, it's likely to mean that you may have to make repayment just as you'd have to repay an overpayment, but taking the initiative and the ability to now utilize this protocol to report when you find a concern is something that is looked at favorably by the government, and as a result often will not impact the operations of an organization quite as significantly. It also is something that I think demonstrates usually that the organization has an effective compliance, a culture of compliance, if not a compliance program. I think compliance programs often will be avenues by which Stark issues are discovered or in the context of the compliance setting. But again, being able to demonstrate that you had compliance activities ongoing or you had checks and balances in your organization to determine when you've had a problem is something that's going to be much more impactful than in trying to reach a better resolution with the government. Two other reforms in progress, and by no means is the list that I'm covering today exclusive of the whole expansive nature of the reforms in the Affordable Care Act, but two things that have recently been rolling out that I find interesting as well are, the first of those is that starting just this year, 2014, in certain states, qualified entities, which can be healthcare providers, including hospitals, community-based organizations, and schools, can actually perform the screening for Medicaid and children insurance program eligibility, and then immediately enroll individuals that are screened and determined to be eligible. That is something that I think has a great opportunity to allow, especially providers like hospitals, to become or to utilize this qualified entity avenue, which states develop the requirements and the process to make these determinations and be a qualified entity. But if you're in that capacity and following those procedures, it allows for services that are provided to someone, an individual that comes in to a provider that was not currently enrolled in Medicaid, to be immediately enrolled and then allow for the ability to receive reimbursement for those services. So it's an avenue by which there should be, and I will be very interested to see the data that comes out in the context of this program in a year or two after it's been in existence for a bit, but to see if that has helped decrease uncompensated care or the inability to collect from trying to bill an uninsured patient because it was someone who was eligible for Medicaid and the provider was able to enroll that person prior to the service. And this is kind of going to not necessarily a new type of care or delivery of care, but I think an opportunity for an expanse to be seen in a type of delivery of care is in regard to federally qualified health centers. These FQHSs, or HCs, sorry, are centers that provide care to populations, usually in a underserved and population base that needs certain preventative services. And they are moving now to being able to utilize the prospective payment system, which will allow them to have a predetermined fixed amount starting just in 10/1. The enrollment actually for this part of the healthcare reform rollout is ongoing. It was starting at the beginning of October and goes through December. So the hope and the goal for this part of healthcare reform is that more federally qualified health centers will come into existence, or those currently in existence will be able to expand their services, because now they'll have a bit more certainty in their payment mechanism, because they'll have Medicare payment made on the PPS system, similarly to how hospitals and other types of healthcare providers receive payment. These centers usually will provide sliding scale payment requirements for patients, and that is expected to continue for those not in the Medicare program, but this is something that should give a little bit more certainty to the delivery of care in these settings. Looking to some of the trends and changes that are coming in the future, this is again a focus on hospital delivery of care specifically, but beginning in 2015, there's going to be a potential penalty for healthcare-acquired conditions. And the way that this will be looked at is if a hospital is in the top 25% nationally of incidents of hospital-acquired conditions, then they can face a 1% reduction in their payment due to being in that level of care. So now when you're looking at all the things that hospitals are going to be both able to be incentivized and penalized for, not just looking at what happens during the hospital stay in terms of the treatment of the condition that the person came to the hospital for, will be considered in what the hospital's payment results from. Rather, now things like if hospital-acquired conditions have come into play, if readmission is necessary based on certain conditions after a discharge, these are all going to be things that can affect the hospital's ultimate payment. And on the flip side, there is the ability to have incentive payments received for achieving certain quality measures, and that's kind of the other side of the coin to having some of these conditions and things that are viewed as being not the same delivery of quality care. There's also a new model of ACO implementation on the federal level that's starting. It's going to be up and running, expected to be for the calendar year 2016, and it's either going to be for existing Medicare Shared Savings Program ACOs or those that are enrolling in the coming year to start in 2016. And this is going to change the way that payment is made so that ACOs, or the ability to change the ways that ACOs are enrolled and receive payment from the ACO program. Specifically, it's going to continue to work in concert with the Medicare Shared Savings Program, but will allow for a tiered system of payment where there are an ACO will receive different payments. They'll receive a fixed payment, they'll receive a shared savings payment, they'll have the opportunity to receive other payments. And so again, I think the intent of this will be, I believe, to give ACOs some more certainty as to they'll know fixed payment amounts that are coming in that they can work with, and then have the ability to reach goals and get additional payments. This will also, I think, then allow ACOs to, and not just because this is the name of it, but to invest more in their operations, because they'll have a different payment framework that they're working with going forward. So that'll be interesting to see how that rolls out. This was just, CMS announced most of the details for this just within October and quite recently. So as this develops, it'll be interesting to see how many more ACOs join due to this new model, and also how many of the existing ACOs move to this new investment model. And then one that I have questions about almost weekly from clients, and there's actually a whole other webinar specifically on compliance programs available on our Health Law blog. But healthcare providers across types under the Affordable Care Act are required to have compliance programs as a condition of enrollment in Medicare. However, the enforcement date for compliance plans to be implemented by providers has not yet been issued. Skilled nursing facilities, the date for their requirement to have compliance plans has actually come and gone now. It was more than a year ago. But other than that provider type, for providers across the board that are Medicare providers, it's coming, and compliance programs are something that there's guidance on from the OIG and from CMS. There's guidance on many fronts as to what the government is likely to be looking at. These aren't things that have yet been, again, said that you have to have a program with X, Y, and Z by this date, but the requirements and suggestions or the framework for compliance programs has been released. There's guidance for provider types across the healthcare industry, hospitals, physician groups, different types of device and equipment manufacturers and providers. So no matter what your provider type, there is guidance likely to be applicable and available, and I would suggest that especially toward the end of the year or as you're looking at your organization going forward, if you don't have a compliance program, or if you have one that you haven't revisited recently or isn't up to date, it's a great time to dust that off or to get one in place, because this is something that is coming, and once the enforcement date is announced, I'm sure there'll be some lead time ahead of that, but that's going to be when everyone's scrambling, and it would be, again, as with many of the other things, less intrusive to your organization and less disruptive to your day-to-day operations if you're taking some of the steps to have compliance ahead of time. As I mentioned, we have lots of healthcare updates and publications on our Health Law blog, so I definitely would suggest you check that out. And we also have many prior webinars that touch on some of the topics touched on here today, especially on things like the fraud and abuse laws. If you'd like to know the basics as to when you need to be considering anti-kickback statute concerns, Stark Law concerns, and then looking towards how healthcare reform has changed those, we have whole webinars devoted to those laws specifically. Additionally, we have some future webinars upcoming, including gifts to and from patients, vendors, and referral sources, responding to requests by law enforcement personnel, and collection issues for healthcare providers. Again, please let me know if you have any questions, and good luck to everyone in this new world of healthcare reform. Thanks very much. Bye.